What's been very clear over the last 20 years, protocol design used to be designing the treatment, and we'll add on a bit of biology to look scientific and fashionable and modern. It's now very much what have you got to offer on the diagnostic front that we can use to design treatment. So the diagnosis of an acute leukemia is, a lot of it's done in the lab. The clinical symptoms are fairly non-specific, and it's in the lab that the phenotypers who do flow cytometry make the diagnosis and decide this is an acute myeloid leukemia, this is an acute lymphoblastic leukemia, and that's done rapidly by flow cytometry. We in the molecular labs come in with the prognosis, with the therapeutics, is that a familiar term? So the molecular subtype determines the treatment. So the most classical example is Gleevec imatinib for BCR-ABL positive ALL. And increasingly that's become a molecular endpoint or a use of molecular results. The other thing we do is, based on prognosis, we then use markers at diagnosis to follow response to treatment or minimal residual disease. So within the T cell world, we have two categories of molecular markers, or molecular and cellular markers. We have the day one markers, the oncogenesis of the tumor itself, and then we have TCR rearrangement markers for minimal residual disease. So to start with the second, we use TCR rearrangements because they're universal markers, because if you've got a group of patients, you want to be able to follow all of them and not just the small percentage that might have a given oncogenic marker. So immunogenetics or flow cytometry is the mainstay of MRD management. And MRD, minimal residual disease, has moved from a nice way of measuring treatment to what's becoming a primary endpoint. And as there's been an increase in the number of different therapeutic options, it's becoming increasingly difficult to just use overall survival or disease-free survival or event-free survival. And there's more and more of a tendency to try to use MRD response as a primary endpoint. Although there are logistic problems to that, because the authorities, the regulatory authorities, tend to group us with biochemistry labs, and they want the precision measurements that you can get when measuring sodium levels. And that's not easy when you're looking at cellular events.